Welcome again to tonight's presentation webinar by Newlife IVF. Today we've got two fantastic specialists presenting to you. We've got Dr. Samir Jatkar and Dr. Chris Russell. They're going to be presenting on some of the earlier treatments that we can offer you in order to help you get pregnant without IVF. Some of these are medical, some of these are surgical. And I'm sure it's going to be an interesting talk. So I'll be back after their presentations to sum up. Cheers.
Thanks, Hugo. We will just go to our slides now. All right. So, as Hugo mentioned, we'll be discussing today some of the non-IVF fertility treatments. So just to recap on what we've discussed in previous webinars, there's four basic things that we need to evaluate for couples trying to conceive. That is regular ovulation, so releasing an egg. The fallopian tubes need to be open so that sperm and egg can meet. We need to have a normal uterus free of polyps and fibroids, etc., that might be stopping the embryo implanting, and we need the right amount of sperm at the right time in the cycle to conceive. These initial or gentler fertility treatments, some people prefer to try prior to moving on to IVF or as an alternative to IVF, include ovulation induction. And that is tablets or injections that are designed to help the female partner ovulate regularly. The second option is intrauterine insemination, or IUI, placing washed sperm into the uterus at the correct time in the cycle. Another option we'll be discussing tonight is fallopian tube flushing with oil or water-based contrast, which might be done awake or alternatively at the time of infertility surgery, which Chris will be discussing as well. It's important to remember that due to that knowledge that there's those four factors that we need to be keeping in mind as to falling pregnant, not all of these treatments will suit all patients. Your fertility specialist will need to perform a full evaluation as to the cause of infertility before recommending which of these might be suitable. The other thing is that these are suitable for younger patients who have a little bit more time up their sleeve to try gentler fertility treatments before potentially moving on to IVF, whereas patients who are already a little bit more at an advanced age may be considering skipping these and moving on to more definitive fertility treatment. Again, just recapping last week as to the broad causes of infertility in a couple. We've got 30% being those female factors like blocked tubes, not ovulating, etc. 30% is a male factor. Now that can be mild male factor or it can be severe. And again, that distinction may determine the suitability of certain treatments, such as IUI being suitable for mild male factor, but not for severe male factor. And of course, there's the mixed factors and unexplained infertility. The other factors that we do need to consider when determining the suitability for these gentler fertility treatments is the need for donor sperm. For instance, single women and people in same-sex female couples, if they're needing donor sperm, the only one of those four options that's really appropriate is IUI with donor sperm. So onto our first gentle fertility treatment, ovulation induction. And as the name suggests, it's mainly for patients who don't ovulate naturally themselves and can otherwise conceive by intercourse. So normal sperm counts, open fallopian tubes, and able to achieve intercourse. So who are the candidates then for ovulation induction? Well, those with irregular menstrual cycles or no periods at all, that group are the ones who are most likely to be suffering from anovulation or not ovulating regularly. We'd want you to have a fairly normal ovarian reserve, and that's partly with respect to not being in a close to menopause situation, or alternatively that we're consuming time if you've got a very low ovarian reserve where more definitive fertility treatment might be more appropriate. We would say that it is more effective in patients younger than the age of 38, and all those other investigations, the semen analysis, the fallopian tube patency, etc., should be normal. The specifics of this, well, there's a couple of different tablet treatments, namely Clomid or clomiphene and letrozole. And both of those are anti-estrogen. So they trick the brain into thinking the estrogen is very low, and the brain then says to the ovaries to produce more follicles and ovulate. What it involves is 5 days of tablet treatment from day 2 to 6 of the cycle. And we usually see that mid-cycle natural ovulation, or it can be a triggered ovulation. Both of the medications we start at a low dose, 50 milligrams of Clomid or 2.5 milligrams of letrozole, and slowly escalate that dose based on the response. And the reason for that is one of the things that we don't want to cause is too much ovulation and therefore increase the risk of multiple pregnancy. The stats for those suffering from the most common cause of anovulation, PCOS or polycystic ovarian syndrome, are that over the course of treatment, even at the maximum dose, we'd get 80% ovulating, half of whom will become pregnant over the 6 months of treatment that we usually recommend of these sorts of tablet treatments. But we also have to be mindful that it's never possible to tell the ovaries to release one egg and one egg only, and hence we would always warn that there's a multiple pregnancy risk, mainly of twins, up to 9%. The other option for ovulation induction is utilising injections. Now, the injection treatment can be used for those who have failed to respond to the tablet treatments. It also is the only option for ovulation induction for those with a condition called hypogonadotrophic hypogonadism. And that's where the brain specifically fails to produce enough FSH and LH to drive the ovaries to ovulate. It's often seen in patients who are lighter in their body weight or low BMI, people who exercise a lot, competition athletes, for instance, and patients who have a history of eating disorders. What this involves is about 10 days of injections with the FSH, and for those with hypo, the LH injections as well. We monitor the response with both blood tests and ultrasounds. And when we determine that the follicles are ready, we give a trigger injections to initiate that ovulation. With these more powerful medications, we'd say at least 90% would ovulate. We have a 10 to 15% pregnancy rate per cycle. But again, the trade-off of the stronger ovulation induction medications is a slightly higher risk of multiple pregnancies of 10 to 15%. And that's despite the close ultrasound monitoring of the follicle numbers during the cycle. Our next gentler treatment is intrauterine insemination. So it's most suitable for those with a mild male factor infertility, or those who are unable to time or achieve intercourse at the right time in the cycle, or for those requiring donor sperm. It can be performed in those who have fairly regular cycles, in a natural ovulation cycle, or actually in combination with the methods I just mentioned, the tablets or injections of ovulation induction. Those who are candidates, again, should be the younger patients below 38 years of age, relatively normal ovarian reserve, and again, all of the other fertility investigations should be largely normal. We would really want couples or females undertaking the intrauterine insemination process to have had fallopian tube testing, just because otherwise there's no way that sperm and egg can meet. So the fallopian tube testing is a prerequisite for those undergoing IUI. It's suitable for same-sex female couples with donor sperm. It's useful for partners where they're unable to time intercourse for whatever reason. I've had fly-in, fly-out workers who are never in the same city at the right time, and we'll freeze sperm and use IUI with really good effect. Or those who are unable to achieve intercourse for ejaculatory or erectile difficulty and other causes, again, we get really good results from IUI because there is actually no problem with the sperm or eggs themselves. It's all about getting them to meet at the right time in the cycle. So the process for IUI is a little bit similar to the ovulation induction. That is, there'll be hormone and ultrasound monitoring of the cycle. We can stimulate with oral or injection medication, and we usually would utilise a trigger injection for timing the IUI procedure to the most successful timing, which is 36 hours after trigger. The male partner would produce a sample, or alternatively we'd thaw a pre-stored sample, and the sample's washed and concentrated, so we've got the best, most motile, normal sperm available, and that sample's placed directly into the uterus. And again, we quote a 10 to 15% pregnancy rate per cycle of IUI. So my colleague, Dr. Chris Russell, is going to continue and talk about tubal flushing and reproductive surgery. Thanks, Chris.
Thank you very much, Samir. Good evening, everyone. And I'll, as Samir mentioned, be taking you through a few other treatments. Before I do, I just want to mention that we love it when these webinars are interactive, and we love taking the questions at the end. It's possible to do to send us your questions through the app. And if you look at the bottom of your screen, there's a little button that says Q&A. If you click on that button, you'll be able to send your questions straight through to us, and we'll be able to answer them all at the end of the presentation. So keep your excellent questions coming. As Samir mentioned, one potential treatment you could consider is tubal flushing, and I guess there's a couple of reasons why you might consider doing tubal flushing, and one of those we would have discussed over the last couple of weeks, and that is to determine whether there is any blockages in your fallopian tubes. But the other reason you might consider doing tubal flushing treatment would be that it does seem to improve pregnancy rates. So it's a fertility treatment of its own accord. People who are good candidates for tubal flushing as a treatment for fertility are people who have unexplained infertility. So if there's difficulties with the sperm, for instance, that make natural pregnancy unlikely, you may not be inclined to use tubal flushing. And it's probably a better treatment when time is on your side. And by that I mean after the tubal flushing, you want to give yourself a little bit of time to conceive naturally. So it might be something we consider as more appropriate in younger patients. The ways of doing tubal flushing, there's a couple of ways of doing it. One is to do it as part of a laparoscopic operation, so a surgical procedure. The other way to do it, of course, is by medical imaging techniques. And regardless of how you go about doing it, the general principles are that a tube is placed through the woman's cervix, and then some kind of fluid is injected through the uterus, and we look to see whether the fluid is able to make its way all the way from the cervix, all the way through the uterus and through the ends of the fallopian tubes. Now, if you're doing that as part of an ultrasound or part of an X-ray, it's the ultrasound that's used to see where the fluid's going. Whereas if you're doing it as part of a laparoscopy, where the surgeon is able to directly look at your fallopian tubes as the fluid passes through with the telescope that they're using. I'll be talking about laparoscopy a little bit more detail a little bit later, just so you know a little bit more about it. But I guess the thing to think about when you're considering tubal flushing is firstly, how do you go about it? And I guess laparoscopy, the difficulty with laparoscopy is that it's a surgical procedure and that there are risks that go with that. It's also a longer recovery time as compared to doing it by X-ray or ultrasound. The X-ray procedures and ultrasound procedures are quite quick. They take somewhere between 15 minutes and half an hour. They can be done just in a medical imaging department. They don't require an anaesthetic, although I must admit they are quite painful procedures. And they are some of the pros and cons. The next question you might ask yourself is, what sort of fluid should you use when you're having your tubes flushed in particular? And recently there's been studies that have compared, or new publications that have compared pregnancy rates following flushing with water and pregnancy rates when flushing with oil. And if you look at this graph over to the right, you'll notice that there's two lines, and the two lines are showing pregnancy rates in the months that follow a flush procedure with oil versus with water. And as you can tell, there's one line that is clearly higher than the other, and that is the line that shows pregnancy rates following a tubal flush with oil. Most of the additional pregnancies are seen in the first 3 to 4 months. Afterwards, there is still a slight divergence in those lines, but they remain about the same distance apart. And what that tells us is that if you do flush with oil, you see most of your benefit in the first 3 to 4 months. So clearly we should all be using oil, right? Well, it's sadly not quite that straightforward. And the difficulty is that we do see some more side effects with oil use versus water. So for instance, there is the chance of allergic reactions with the oil. As a result, you've got to be very careful with how it's done. You have to be quite judicious with how it's done. Some people suggest that it should only be done in a hospital setting or even in an operating theatre. Certainly it's safer to do it as part of a laparoscopy than it is to do it in the medical imaging department for that reason. The other is that it can have other side effects, and in particular on the patient's thyroid. We do see some reduction in thyroid function that follow, not always, but sometimes follows the use of oil. So it's not completely clear cut, and this is something you'd need to discuss with your fertility specialist. The other is that the oil is outrageously expensive, and if you see the little picture of that vial of oil down the bottom of the screen, that's 10 mils of oil, and it costs in the vicinity of $500, and there is no rebate for that from Medicare, so it is quite an expensive treatment. Which brings me to more broad surgical treatments. And I'm just going to talk to you about the types of fertility surgery that can be done to increase your chance of pregnancy. And broadly, you can sort of break it up into operations that can be done for the woman and operations that can be done for the man. And the most common surgical procedure that's done on men to help them have a baby is if they've had a vasectomy. So if they've had a vasectomy performed for contraception, usually in a previous relationship, that you can undergo an operation to stitch the vas deferens back together. In some circumstances also, some tumours or masses in the scrotum can be removed, and that improves, that has been shown in some circumstances to improve a man's sperm count and therefore chances of pregnancy. Generally, the operations done on women are performed by laparoscopy and hysteroscopy by a gynecologist. It's always a good idea to have your surgery done by a gynecologist who specialises in fertility treatment, because they will always have in mind your future fertility. Contrastingly though, the operations that are done for men are generally done by specialist urologists. Generally, your fertility specialist can advise you when these operations might be beneficial and arrange the appropriate referral. So the types of fertility surgery that you can have done are hysteroscopy and laparoscopy. The hysteroscopy is an operation done in a hospital under a general anaesthetic. So you're fully asleep, totally unaware, and won't remember the procedure. There's no cutting at all. All it involves is stretching open your cervix a fraction so that we can put a telescope through your cervix and look inside your uterus. And the recovery is quite quick. Usually you're back on your feet and feeling fine within a day or two. There are some very small potential risks. There's always a risk of infection with this type of operation. In very unusual circumstances, you can create a passage through your uterus, which means it needs a little time to heal afterwards. But those complications are very rare, so it's a very well tolerated operation. The other operation that can be done is a laparoscopy. And this again is an operation that is done in an operating theatre of a hospital under a general anaesthetic. And often the two procedures are done in conjunction. So some patients, just about every patient who has a laparoscopy will also have a hysteroscopy at the same time, although not necessarily everyone who has a hysteroscopy will need to have a laparoscopy as well. So a laparoscopy is most well known as keyhole surgery. So it's a keyhole operation, meaning that all of the operating is done by the surgeon through very small incisions in the patient's abdomen. And if you look at the picture on the right, you can see that the instrument on the right is a camera, and the instrument on the left is being used to move the uterus, tubes, and ovaries around. And sometimes the operation is done through 2 small incisions. Sometimes, if there is actually things that need to be fixed, it's done through 4 small incisions. It's usually a day procedure, meaning that following the surgery, you go home and don't need to stay in hospital, although that's not always the case. The recovery time generally is around about 3 to 5 days. So a lot of my patients are able to go back to work relatively quickly, although you always do need a day or 2 on the couch to recover. The main negative to having a laparoscopy is that there's potential risks from the surgery. And whilst they're not common, we usually suggest the risk of serious complications is around about 1 in 1,000 operations, meaning it takes 1,000 operations for there to be one significant complication. However, those complications are quite significant, and they can include damage to important blood vessels running through your abdomen, or damage to the bowels, which sit very close to the uterus, tubes, and ovaries. Again, they are uncommon, but they would mean, if that was to occur, it would be a much longer recovery and would probably require additional surgery to fix it. So who is a candidate for having surgery to improve their rates of pregnancy? And I guess, broadly, we would say anyone who wants to increase their chance of natural pregnancy through flushing, and if they didn't consider that doing it as part of a medical imaging procedure was right for them. So if it was a patient preference to have it done under a general anaesthetic. If there were symptoms, if the patient had symptoms that suggested there might be a problem, so such things as pelvic pain would be a very important one, because that can sometimes suggest that the patient has endometriosis. The other situation would be if an ultrasound, and an ultrasound is usually done as part of an earlier fertility workup. If the ultrasound has found something that needs to be fixed as part of the laparoscopy, so the sort of things that you would see would be perhaps fibroids. You sometimes see signs of endometriosis on the ultrasound, although not always, or polyps or problems with the fallopian tubes. So I could talk about endometriosis all night, and Hugo could probably talk about endometriosis for a week, but I'll try and do it in 1 or 2 minutes. But endometriosis is a condition where the lining of the uterus, called the endometrium, grows in places that it shouldn't, usually around the uterus, around the ovaries and the fallopian tubes. And it can be very hard to know it's there. And in fact, some people who are having difficulty getting pregnant don't even know it's there, but it's there in about 30% of cases. Endometriosis is more likely if you have symptoms. So when we say symptoms, we're talking about pain, and that can be painful periods, particularly pain that's getting worse with time, pain that's associated with difficulties, or pain that's associated with using your bowels or bladder, or pain that's associated with intercourse. How does surgery actually help? So we do notice that patients who have their endometriosis treated surgically have higher natural pregnancy rates for a period of time that follows. And we think that by removing the endometriosis from around the tubes and ovaries, we're creating an environment that's more favourable for the egg at the time of ovulation. We also think that endometriosis affects tubal function. And what I mean by that is, to get pregnant naturally, the fallopian tubes have to be able to move the egg into the uterus. And we feel that endometriosis probably inhibits that. As well as better natural pregnancy rates, we also see that patients respond better to IVF following the removal of endometriosis. And generally what we find is that more eggs generally are retrieved, which is usually a lead into better success rates. The one confounding area is whether removing an endometrioma or a chocolate cyst is a good idea or not. And just to fill you in on what that is, if you get an ovarian cyst that is caused by endometriosis, that's what we call an endometrioma, sometimes called a chocolate cyst based on the appearance that we see at surgery. The difficulty with those is if you do have an endometrioma removed surgically, it is impossible to remove an endometrioma without removing a very small amount of ovary with it. And as a result of that, you end up with lower egg numbers in the recovery period time following the operation. So you will have less eggs as a result. Sometimes it's inevitable and it must be removed, and the situations where an endometrioma really should be removed is if the patient is experiencing significant pain. The other time would be if you were proceeding with IVF treatment and your specialist felt that the cyst would make it difficult to collect your eggs. That would be another situation where you might want to remove it. But I would summarise by saying endometriomas don't always need to be removed. The other things that we can fix surgically or help with surgically are fallopian tubes, and in particular a thing called a hydrosalpinx. And the picture on the right shows some fallopian tubes that are really quite abnormal. They've been affected by an infection usually, and it causes swelling and fluid buildup within the fallopian tube. The difficulty with that is that those tubes are often blocked, and as a result, if a fallopian tube is blocked, that makes it harder to become pregnant. Particularly, it makes it virtually impossible to become pregnant through that fallopian tube, and you would hope that the other one is normal. But further to that, when an embryo tries to implant into the lining of the uterus, the presence of a hydrosalpinx reduces the chance of that embryo implanting, and it does that by allowing toxic fluid to ooze into the uterus. And we know that patients are much more likely to get pregnant following the removal of a hydrosalpinx, both naturally and through IVF. So if there is a hydrosalpinx there, it really is best to remove it. It is a little bit counterintuitive, and a lot of my patients get very worried when I suggest removing their fallopian tube. But you've just got to make sure that you ask lots of questions and that you understand the reason why it's being done. Surgery for blocked fallopian tubes is very difficult, and a lot of patients with blocked fallopian tubes ask me, can I have surgery to fix it? And it's actually very uncommon that surgery will work, usually because the surgery to correct blockages often causes more scarring than it fixes. The one instance where we think that surgery might help is again with tubal flushing. There could be some very fine minor blockages in your fallopian tube that are flushed through and unblocked by the flushing process. But if that fails to work, there's really not a lot we can do. And in that circumstance, with blocked fallopian tubes that can't be fixed with a flush, you really need to be considering IVF to get pregnant. Uterus problems can sometimes be fixed surgically, and fibroids are a very, very common finding on ultrasound, although I would hasten to add that not all fibroids cause problems with pregnancy, and you don't always need to worry about them. Generally, the types of fibroids that you should consider surgery for are if they are very big, or if they're growing into the lining of the uterus. So if you look at the picture on the right there, the fibroid that's sitting at about 3 o'clock, and I'm not sure if you can see my mouse moving over it, but that one there is growing into the uterine cavity. And as a result, that can affect how a pregnancy implants and lead to either not becoming pregnant at all or sometimes miscarriages. And these types of fibroids can be removed and potentially improve your pregnancy rates. And I've lost my way here. There we go. The other thing about these types of fibroids is they are amenable to removal by hysteroscopy only, so without any major cutting. So it can all be done through your cervix, which means the recovery is quite quick. By contrast though, big fibroids that grow on the outside of your uterus, you need an abdominal incision of some sort to remove those. So that can be done either laparoscopically, so by keyhole surgery, or sometimes when that's not possible, an open operation is required. And by open operation, what I mean is a sizable incision on your abdomen that's big enough to remove the fibroid through. Endometrial polyps are a very common finding on ultrasound, and as a general rule, it depends on their size whether they will affect the chance of pregnancy or not. But generally, once a polyp is over 10 to 15 millimetres, they will make it much harder to become pregnant, and they should be removed. They are very easy to remove in that it's usually a simple hysteroscopic procedure. We pop the camera in, have a look and see where the polyp is, and then grasp hold of it and pull it out. And sometimes it does need to be cut out, but again, doesn't involve cutting into the uterus itself. So it's a very safe procedure. A uterine septum. Now, a uterine septum is this thing here. And what that is, that's a condition that you are born with. And it is quite rare. It's the sort of thing that can be sometimes diagnosed on ultrasound if it's particularly big, or sometimes can only be diagnosed on when you have a hysteroscopy. And in certain circumstances, we would consider repairing a uterine septum. The sort of instance where we would consider it is if there had been a number of miscarriages, if it was, or if there was quite a prolonged course of infertility. So either a very long time not conceiving naturally, or if you'd had a number of embryo transfers through IVF and they weren't working, we would consider fixing a septum then. The reason we don't rush to fix septums is it is quite a lot more involved than removing a polyp, for instance. And we have to slice into the tissue of the uterus, and then we have to use hormones to regrow the lining. So it's not something you'd really want to do unless there was an identified problem that we felt was being fixed by the surgery. So that's the end of my presentation. We will now move on to questions. And so I might have a look and see what we've got here and invite Samir up. But whilst Samir is coming up, I might take the first question, which is, do you guys offer Lipiodol tubal flushing? And so firstly, just to introduce what that is, you might recall when we were talking about tubal flushing, we were talking about whether you should use oil or water. So Lipiodol is the trade name for the oil. I do personally do Lipiodol flushing in some circumstances, and so the short answer is yes.
Okay, so the next question I'll address is another one about tubal flushing, and I think it might have been asked just before Chris's presentation, which is there an option to have a tubal flush with anaesthetic? Yes, but that would be part of a laparoscopy procedure under a general anaesthetic, as opposed to the awake procedures which are done under ultrasound or X-ray, where it's not possible to have a full anaesthetic. That said, I always tell my patients if they are having those awake tubal patency tests to have some pain relief, that is tablet pain relief about an hour beforehand, and that does make the procedure quite tolerable. The next question I've got is, how often would you recommend a tubal patency test? That is, if one was done 2 years earlier, would you do another? Is there a possibility of blockage arising? The short answer is yes, of course, you can repeat tubal patency tests. It is possible that you've acquired damage to the tube over time due to infection or endometriosis, and that the situation 2 years ago has changed. The other question I often deal with are patients who've had a water-based flush who then come back and say, well, that was normal, we still haven't conceived, should I do a oil-based flush? And that certainly is an option. The only issue is that if you haven't conceived after 2 years, it might be reasonable, depending on your age, to move on to more definitive fertility treatment. But certainly if you're, again, younger patients, you've got time up your sleeve, it's absolutely fine to have a repeat procedure down the track. The other thing I would say is that a lot of these studies, and the graph that we put up earlier was from the largest New England Journal study, do look at 6-month follow-up from the original tubal patency to determine success or not. Good. The last one I think I'll address before Chris. Before Chris comes back and answers a couple more, is my previous doctor flushed my uterus with filgrastim and HCG, and what are these? Okay, so these are less conventional medications that people sometimes flush into the uterus, and I guess the vogue or fashion for using these agents has come and gone. Initially, the data on HCG flushing into the uterus as part of an IVF cycle came out of a really small study in Egypt. And it was only found at the higher doses of HCG infusion and only in day 3 embryo transfers. So I know that clinically we did, based on that trial using HCG, and essentially we didn't feel that it worked. And so that's gone out of fashion. Filgrastim has been used in various methods to improve thin linings. So in and of itself, in the absence of a thin lining, I personally don't use filgrastim and don't recommend it. And really those sorts of agents are not part of routine fertility treatment. I think you need to have a really detailed discussion regarding the pros and cons of those medications, partly because they're not proven definitively in IVF treatment, but also they're very expensive and not covered by the PBS. So again, it's really something that you've got to discuss in quite a lot of detail with your specialist as to the rationale for using those without much evidence.
Thanks, Samir. I've got a question by email, which is, do we recommend FSH ovulation induction treatment in patients who are already ovulating? And I think what this question's getting at is do we use FSH as a means of having a woman release more eggs each month in an effort to improve her pregnancy, her natural pregnancy rates? And the short answer is yes, we do that in certain circumstances. And the advantages of doing it is that if we are able to, through using the FSH injections, get a woman to release 2 or sometimes 3 eggs, we are going to see an increase in her natural pregnancy rates. What it's really important to understand, though, is if you release 2 eggs, sadly, it does not double your pregnancy rates for that month. It increases them slightly. What we do see an increase in, though, is the twin pregnancy rate and the multiple birth rate. And generally, we see a twin pregnancy rate of around about 25% when we use FSH injections to help a woman release multiple eggs. And we sometimes even see triplets and high-order multiple births. The triplet rate we would think is probably around 1% or maybe slightly lower. The difficulty with all that is that as a patient, if you are considering doing that sort of thing, you'd have to be accepting of those risks of multiple birth, and also understanding that it doesn't lead to a dramatic increase in natural pregnancy. However, it's probably a useful treatment in patients who don't want to consider doing IVF, and particularly if otherwise everything is quite normal, as in you have patent fallopian tubes and the man's sperm test is normal. Conventionally, FSH ovulation induction is used more in patients who are not ovulating, usually due to polycystic ovary syndrome. And like I mentioned, with the increased rates of multiple birth, you have to be extraordinarily careful when you're using FSH to make sure that the number of eggs released is known at the time of ovulation. Let me just have a look through and check that we've answered all the questions. Okay, so I've got, if you are young, for example, 27 and normal ovarian reserve, how many cycles of injectable ovulation induction would you normally recommend before moving on? And would IUI be a better option if not conceiving with OI? So that's a little bit similar to the last question. And I would say, when you're 27, you do have time on your side. So regardless of what non-invasive or non-IVF treatments you pursue, you do have quite a lot of time to pursue them. So I've had some patients who have done many, many, many months of FSH treatment and have led to a pregnancy eventually. So I think it's just got to be a question of discussing your particular circumstances with your specialist and saying, is there still a chance of pregnancy by pursuing FSH ovulation induction? And if there is, what is the chance of success? And then weighing it up against the alternatives and making a decision based on what you would prefer. But certainly, I would think 4 months to 6 months of injectable OI would not be unreasonable. But like I mentioned, I have had some patients who continue for much longer because they don't want to do IVF in particular. The next part of that question is, would IUI be a better option if not conceiving with regular ovulation induction? And statistically, you'd say yes. Intrauterine insemination does lead to higher pregnancy rates than by having ovulation induction and natural pregnancy. The difficulty, again, always with IUI is the individual patient's suitability to that treatment, and weighing up the increases in pregnancy rates that you will see versus the increase in pregnancy rates you would see with pursuing IVF instead. And most people would agree that IVF pregnancy rates are dramatically higher than natural and dramatically higher than ovulation induction treatment, whereas IUI offers more modest increases in pregnancy rates. So again, I feel like I'm talking on a financial podcast, but it's hard to give personal advice without knowing all the details. But I hope you found that answer useful. So I think we are through all the questions now. So I want to thank you for your attendance, and Hugo's going to jump on. So we'll welcome back Hugo, and thank you for attending, and have a good evening.
Thanks, Chris, for that. It's another great presentation by my colleagues, Dr. Chris Russell and Samir Jatkar, both looking rather dapper in their suits. I've gone a little bit more COVID casual. On the issue of COVID, there's really nothing to update you guys on. I know you're all hanging out for some great information, but there's nothing at the moment, unfortunately. Really, the only thing to add since at my last presentation or talk to you guys is that we're still doing ovulation induction. That was something that we're able to sort of push through the government. We can do ovulation induction, which Samir spoke about earlier, using injections or tablets, and most of us run those out of our rooms, or you can run it through Newlife IVF. Unfortunately, we can't offer you IUI with that, but as Chris just finished talking about, ovulation induction with injections is certainly going to be better than doing nothing. We're hoping with that also surgery will start up soon. It's a credit to everyone that Victorians and Australians have been able to flatten the curve, and we hope that continues. Next week, we have another two specialists. We've got Dr. Chris Russell and Amber Kennedy, one of our newer doctors, presenting on IVF specifically, and explaining sort of the ins and outs of what's involved in that. So we hope to see you again same time next week, and bring some of your friends along maybe, and get your questions prepared. So cheers.